Hi everyone and welcome back. In this part of lecture, we're going to explore what it means to die and how the related death rituals, practices, and customs have changed over time. Death in America looks very different today than it did even 60 or 70 years ago. Certainly death has existed since life began. For something so commonly shared and experienced, it has not had the same degree of study as other topics. Even so, records dating back to the Middle Ages shed light on how the Western world looked at this important aspect of the life cycle. Ars Moriendi, or the Art of Dying, is the name of two related Latin texts dating from 1415 and 1450, which offers advice on the protocols and procedures of a good death and on how to, quote, die well, at least according to Christian precepts of the late Middle Ages. It was written within the historical context of the effects of the macabre horrors of the Black Death 60 years earlier and consequent social upheavals of the 15th century. It was very popular, was translated into most Western European languages, and was the first in a Western literary tradition of guides to death and dying. Obviously, more work has been done on the study of death and dying since then, as we learned in an earlier lecture when discussing the field of thanatology. In this lecture, I want to take a more personal look at what death means and how it has been experienced in America over the past almost 2.5 centuries. We'll explore how and why death moved from the home to the hospital, from family to morticians, from daily conversation to taboo, from rural ebb and flow of life to urbanization and mechanical support. This poem, entitled Grandmother, When Your Child Died, by Joan Neate George, illustrates the dichotomy in the death experience. Listen and follow along as I read her poem aloud. Grandmother, when your child died hot beside you in your narrow bed, his labored breathing kept you restless and woke you when it sighed and stopped. You held him through the bitter dawn and in the morning dressed him, combed his hair. Your tears welled, but you didn't weep, until at last he lay among the wild iris in the sod, his soul gone inexplicably to God. Amen. But grandmother, when my child died, sweet Jesus, he died hard. A motor beside his sterile cot groaned and hissed and whirred while he sang his pain, low notes and high notes in slow measures sipping through the drug cloud. My tears, redundant, dropped slow like glucose or blood from a bottle, and when he died my eyes were dry, and gods wearing white coats turned away. What do you think? What were your reactions? How far we have come in such a short period of time, and yet many would ask, which is really better? Although technological advances allow us to keep people alive longer, is that always best? And for whom? These are important questions to think about as we begin this class. Let's learn a bit more about this by first exploring how the death experience has evolved over time in America. Specifically, we'll look at early America, the Civil War era, and then current practices, taking note of how the following characteristics help to shape the death rituals and practices of the times. We'll look at things of importance such as location, lifestyle, both social, economic, and political, the immediate needs of the dying, as well as resources available at that time. Certainly, we all realize that death can be seen as personal or in the collective as just a part of life and something one has to distance themselves from in order to cope with mass casualties. Finally, cultural or religious customs play an important role as well, and we'll come back to explore those aspects in more depth later this semester. For now, let's begin with a look at death in early America. Death in early America was vastly different than what we experience today, and there are many reasons why. As we consider the needs and characteristics of the time, we see a number of things that played an important role in how death was experienced and dealt with. For starters, we saw great diversity in the types and circumstances of one's life. Many early immigrants first settled in urban areas where work, usually in the form of hard labor or domestic help, were more readily available. Over time, and as the government made land available for purchase or homesteading in the West, individuals and families began to move into new, uncharted, and rugged terrain. As with any nation that is newly developed, there was great disparity in resources. Some families were very wealthy and had fine material possessions and opportunities. Many others, as is common among immigrants, struggled just to survive. We therefore saw great differences between the upper and lower or working classes. During this time, there was very limited access to medical care. There were some doctors and nurses who worked out of their homes or in hospitals in the urban areas, but their knowledge and resources were limited. Many of the world's great medical discoveries had not yet occurred. For many, there was no access to a trained physician, so someone in the family or rural community provided traditional healing care the best they could. Disease was rampant. There was no such thing as a sterile environment, standard precautions, or even vaccinations. Many illnesses spread quickly, and people died. Infant and child mortality was very high. Individuals died not just from exposure to disease, but also to the elements. Heat and cold-related deaths were high. Accidents and injuries working in the factories, on the boats, in the mines, or on the farms led to many casualties. Indeed, death was seen and experienced as a common, natural part of life. When someone died, everyone participated and was involved. Women washed and prepared the deceased body, dressed them, and laid their body in the home's parlor. They hosted visitors, typically for anywhere from 2 to 5 days, who came by to pay their respects. At the same time, women prepared food and drinks, accommodated visitors overnight, and kept the daily routine of the home and family running smoothly. Men were also hard at work, cutting wood to build the casket, digging the grave, even making some type of grave marker. Children were not sheltered or hidden during this time. Rather, they weren't just observing, but they were actively participating in these tasks. Depending on their age and gender, they were either helping their mother or father and the other family members best prepare. In the photo here, we see 2 children dressed in their Sunday best, waiting to welcome visitors coming to mourn the death of their younger sister, seen lying next to them in their parlor. The Civil War from 1861 to 1865 brought many changes in medical care. In fact, while advanced or hygienic may not be terms attributed to medicine in the 19th century, modern hospital practices and treatment methods owe much to the legacy of Civil War medicine. There were mass casualties, and the sheer number of injured soldiers pushed Americans to rethink their theories on health and to develop efficient practices to care for the sick and wounded. Of the approximately 620,000 soldiers who died in the Civil War, 2/3 of these deaths were not the result of enemy fire, but of a force stronger than any army of men: disease. Diseases such as dysentery from drinking contaminated water, diseases like typhoid, pneumonia, measles, tuberculosis, even malaria were rampant. Soldiers lived in close quarters, and disease spread quickly among the ranks. In addition to disease, another factor that played a critical role in the Civil War was the practice of amputation, as we see in this image here. Many soldiers suffered battlefield wounds or even frostbite, and that required the quick removal of damaged limbs. Photos of piles of feet, legs, hands, and arms were visual indicators of not only how brutal combat could be, but also were a sign of the many lives saved due to this practice. Techniques were still fairly crude, however, and infection following surgery was common. Physicians and medical teams quickly established mobile hospitals on the perimeter of battlefields and tried to provide treatment the best they could. In fact, this was an early introduction to the triage system. According to CivilWar.org, once the soldier was wounded, medical personnel on the battlefield bandaged the soldier as fast as they could and gave him whiskey to ease the shock and morphine if necessary for pain. If his wounds demanded more attention, he was evacuated via Letterman's ambulance and stretcher system to a nearby field hospital. Their triage organization was very similar to the system that physicians use today. Field hospitals separated wounded soldiers into 3 categories: mortally wounded, slightly wounded, and surgical cases. For medical practitioners in the field during Civil War, germ theory, antiseptic medical practices, advanced equipment, and organized hospitalization systems were virtually unknown. Medical training was just emerging out of the heroic era, a time where physicians advocated bloodletting, purging, blistering, or a combination of all 3 to rebalance the humors of the body and remedy the sick. Physicians were also often encouraged to treat diseases like syphilis with mercury, a toxic treatment to say the least. These aggressive remedies of the heroic era of medicine were often worse than patients' diseases. Those who overcame illness during the Civil War owed their recoveries less to the ingenuity of contemporary medicine and more to grit and chance. Luck was a rarity in camps where poor sanitation, bad hygiene, and diet bred disease, infection, and death. Just as we saw changes in medical care, this time period brought about the need for different funeral and burial customs. The Civil War drove the need for a new science, an improved way to handle the dead. So many men died and so many were far from home, there was a growing need for a way to preserve a body for a decent burial once the body arrived home. Families wanted to see their fallen sons once more, and railroads added to the urgency by refusing to carry decaying bodies, which were identifiable by smell. As the war continued, embalming physicians began to follow the action and would take over a barn or a shed near the battlefield or set up a tent and embalm bodies there. Embalming of the remains was a great scientific advancement, but it was too expensive for most people. Since officers tended to be from well-to-do families, embalming physicians instructed soldiers to bring the bodies of officers only. Then the physician would work out payment with the grieving family. According to War Drive's advances in 2011, some physicians were unscrupulous, and they charged extraordinary fees or even threatened to hold the body hostage if the family didn't pay. The reality, though, was that the carnage was often so vast that there was little hope of getting the majority of soldiers home. Communities near battlefields had little choice but to go out to help cover the dead or put them in mass graves. Prior to the war, funerals tended to be private affairs situated firmly within the domestic sphere. But as the death toll rose, funerals became daily public events in cities across the nation. With men dying hundreds and thousands of miles away from home, strangers increasingly performed many of the rites associated with death. Rather than finding eternal rest in a family plot, many Civil War soldiers were buried on the fields where they had died. Despite the staggering numbers of dead, during the war, elite and middle-class women frequently tried to mitigate the impersonal and anonymous burials of soldiers by attending their services, writing letters home to the soldiers' families, and placing flowers on military graves. With the end of the Civil War, the practice of embalming died out for a time, since people were more likely to once again die near home and could be buried more quickly. Embalming surgeons became a thing of the past, at least for a while, and when interest in embalming returned again in the 1890s, undertakers began to perform these duties. Companies that wanted to sell embalming fluid sent salesmen around the country to demonstrate the process and provide certificates of training, and the practice grew. We'll take a closer look at the funeral home industry later in the semester, but it's important that we understand how its roots developed back in the late 19th century. What we see today has some commonalities and some differences with what occurred during the first 2 centuries in America. Rather than dying and being cared for in the home or on the battlefield, most people today die in institutions, such as a hospital or nursing home. Why do you think this is? Take a moment to jot down your ideas. You can go ahead and push pause and then push play when you're ready to continue. There are many reasons, of course, but some of the bigger, more overarching themes include the following. Changes in family roles, responsibilities, and organization. In centuries past, it was not uncommon to have multiple generations living and working together. There could easily be 3 or 4 generations of family who all resided in the same house or the same area. Taking care of the ill and aged was just part of what the family did. As technology grew and people became more mobile, we saw sharp decreases in the number of multi-generational households. With this, so too changed the roles and responsibilities for those family members. People lived farther apart and therefore could not assume the same duties or caretaking tasks as generations previous had done. Next, we have to consider the social and financial pressures. In the late 1800s, we began to see almshouses appear. These were the early nursing homes, often founded by women and church groups to care for the aged, the elderly, physically disabled, orphans, and mentally ill. Over time, different institutions were built that separated and provided more specialized care for these groups. But even up through the 1920s, nearly 70% of all residents in almshouses were the elderly poor. Nowadays, we realize that our present-day nursing homes are anything but cheap. Depending upon the type of facility, they may or may not accept Medicaid. They have strict regulations for Medicare, and many operate primarily on private pay. This then creates a disparity, where we have some nursing homes caring solely for the elderly poor, and others with fancy chandeliers and fine dining who cater and care for society's upper-class elderly. Depending upon a family's situation, they may not be able to care for their loved one at home, either due to social responsibilities, preferences, complex needs of the patient, or limited financial means. Or they may prefer to have the elderly living in a nursing home because it's easier for them. Maybe they can afford the best care, or it's just how their family does things now. Finally, we need to acknowledge that cultural expectations and preferences play a huge role as well. In many families, no one would even consider placing their loved one in a nursing home or hospital to die. They would provide care at home and make whatever arrangements or sacrifices needed in order to do so. For others, they'd never consider caring for the person at home, so they would prefer a hospital or nursing home setting instead. In some cultures, there's a specific person that assumes caregiving duties, such as the oldest daughter, or maybe the aging parents are expected to move in with the oldest son. You'll want to talk with your patients to figure out what will work best for them within the context of their own family. There's not really a right or wrong reason for everyone, as each situation is unique. We all know that facilities are vastly different. Some are clean and warm and inviting. Others are dingy, poorly lit, and standoffish. Many times, hospitals and nursing homes feel more sterile or impersonal than one's own home. And just by nature, families and friends become more removed from the ill or aging person, and therefore more removed from death. As we think about these different environments, let's take some time to consider a few important questions. It's easy for us to say that everyone should do this or that, but unless we take the time to critically analyze each individual situation, we cannot come close to understanding why families do what they do. Rather than judging, let's first consider the factors that play a role in these difficult decisions. What are some of the reasons a patient may prefer to die at home? Why might they prefer to die in a hospital? Or maybe in a nursing home? What are some of the pros and cons of each of these environments? As you think about this, I want you to look at it from different angles. What are pros and cons socially for that patient or resident? How about emotionally, logistically, even financially? Now that we've thought about these factors from a broad perspective, I'd like us to consider them from a more personal standpoint. What experiences have you had? What was positive? What was negative? And if you got a chance and you were able to pick one of these 3 places to die, home, hospital, or nursing home, which would it be and why? We cannot truly explore these issues without acknowledging the role that technology plays in the conversation on death. Technology allows us to save people who would otherwise die. The question is, though, should all technological means be used in all cases, or should patients and families have a say in what is or is not done for the patient? It then becomes an ethical issue as well. This notion is known as the technological imperative. The idea is that if the technology exists to do something, then it should be used, regardless of how much money it's going to cost or the ultimate quality of the outcome. Take this scenario, for example. Mary, as we see on the screen here, is a 53-year-old physician who suffers a stroke one day while at work. The medical team quickly stabilizes her and intubates her. As physicians conduct tests, they discover that the stroke was massive, and Mary will not be able to breathe without mechanical ventilation. What do they do? Do the doctors' views differ from her family's? Had Mary ever shared her wishes with anyone about life-sustaining treatment? If Mary will never be able to breathe again on her own, should they keep her on the vent, or should they remove it and allow her to die peacefully? These are difficult issues that we'll continue to explore in more depth throughout the semester, but they really get us thinking about this technological imperative. Just because we can do it, does that mean we should do it? Maybe yes, maybe no. There's not always a clear-cut answer. Let's go back to Mary and her scenario. This time, instead of a physician, let's say that Mary is a 53-year-old waitress. Would that make a difference? Does her social status or profession make a difference in what the physicians are going to encourage the family to do or not do? Does the family's ability to pay for expensive, possibly even futile care make a difference? Would the doctor know more about the realistic outcomes and thus be less likely to want this type of care? Or would the waitress and her family be more likely to hold on to false hopes? These are all interesting to think about, and they raise important questions about how life is valued, or some lives valued more than others. What we end up seeing across the board is that employing technology allows many people to live longer. However, this may bring about a rise in the number of patients living with chronic illness. It can certainly lead to more expensive healthcare costs, and it draws out or delays the dying process. Even so, there are benefits at times, pros and cons. When do you think this would be most beneficial? In what types of situations? On the flip side, when could this be seen as potentially futile or not worth doing? The increased push for doing everything technologically possible becomes further complicated when we see how the definition of death itself has evolved over the years. For thousands of years, there was just one essential definition of death: when the heart stopped beating. When someone's heart stopped, they could not circulate blood, they could not breathe, and they would die. This is described as clinical death. As we've learned more about the body and the brain, our conceptualization of death has become more complex. We see this kind of in-between death status called cortical death. In this definition, the neocortex of the brain has died. The person is in what the physicians term a persistent vegetative state, or PVS for short. This is a permanent condition. While the patient may appear to be awake, possibly even with their eyes open or breathing on their own, they have no awareness of what is happening around them. They cannot think, they cannot feel. They may have some reflexes still intact, however, which is what makes this very confusing for families to understand. The person may look alive, but they are not able to have any type of thought process or emotional interaction with others. The term brain death refers to a condition in which there has been some type of injury or trauma that leads to permanent absence of cerebral and brainstem functions. In these cases, the person is already dead. Their physical body may be able to be kept alive by mechanical ventilators and artificial nutrition and hydration, but their brain, which controls all aspects of life, is already dead and no longer functioning. Brain death is a step beyond cortical death. In these cases, there are no reflexes remaining. For example, their pupils will not dilate when light is shined on them, they will not cough when their vocal cords are tickled, or have any other reflexes. They also cannot respond to pain. Doctors have tests that check to see if the patient can feel anything, and when someone is brain dead, they will always yield a negative or absent result. There is no chance to reverse the damage to the brain in these cases, and the only thing keeping the person alive is mechanical and artificial means. The final term we need to look at is biological death. Once the person's heart stops beating, either naturally or mechanically, and there is no more blood flow or oxygen being carried to the body, they will experience biological death. The body cannot function independently, and cells begin to die. When this happens, several things occur. I've outlined some of them on the slide here for you to see. The eyes lose their reflexes, body temperature begins to fall, the blood begins to pool as it's no longer circulating. The body begins to float with gases that cannot be expelled. Muscles will stiffen tightly, and decomposition begins. Depending upon how much time has elapsed since the person died, they may have experienced some or all of these changes. In fact, these are things that the coroners look at when determining time of death. As we look at what it means to die and these various complex definitions of death, we need to acknowledge that there is pressure to redefine death yet again. For more than a decade, there have been physicians, ethicists, and regular people like you and I who would like to see cortical death, or PVS, also determined as brain death. PVS is permanent, and many feel it would make it easier for medical teams as well as families if they didn't have to decide whether or not to keep that person alive via artificial nutrition, hydration, and in some cases, mechanical ventilation. It would, in essence, reduce the need to decide when to quote-unquote pull the plug, because the person wouldn't be hooked up to all those things in the first place. Of course, as with anything involving real people and real emotions, there are arguments both for and against this change. What arguments do you think people would have for changing this definition? What positives or negatives would come from this? At the same time, what arguments would people have for leaving PVS separate, as it's not considered brain death currently? What are the positives and negatives of keeping the definition as is? In order to provide the best patient care in light of this newer and changing conception of what it means to die, we have the opportunity to help redefine hope at the end of our patients' lives. We don't have to give up hope. We don't have to be unrealistic either. We can focus on our interactions and their quality of life in the here and now. To do this, I found 3 questions at the end of life to be pivotal. Whether it's the patient, the family, the medical team, or hopefully a discussion among all 3, we need to look at the following. When is enough enough? What takes priority? Quantity of life or quality of life? How can we shift our focus of hope from cure to comfort, or from forever to this day, or to this moment? In essence, we're helping patients and families to redefine their hope. Maybe you don't hope you live for 10 more years or even another whole year. Maybe your hope becomes hope for a pain-free afternoon, or hope for a nice visit from family, hope for maintaining dignity. As we consider these questions, we also want to be thinking about what options are available to our terminal patients and their families. Do they want to actively try to combat their disease or illness? Do they just want to buy some time or delay the dying process? Do they want palliative or hospice care? Or do they want to do nothing? At the same time, we need to consider where they live or could be living. Are they in a hospital, a skilled nursing or assisted living facility? Do they live at home or with a family member? Do they receive any home health care services? All of these things must be factored into the decisions that patients and families must make, and our job is to support them along the way. We don't want to give advice or tell them what to do, but we do want to listen, comfort, and provide information about what options exist. Then we support them until the end, whenever that may be. Let's take a few minutes to differentiate between palliative care and hospice care, since these are important terms we'll be using all semester. Palliative care is an extra layer of support for people experiencing serious and chronic illnesses. It's meant to improve the quality of life, be it in body, mind, and spirit. The idea here is to provide relief from symptoms, from the side effects of treatment, and from the stress of living with a serious illness. One of the goals is to protect the patient from discomfort or pain. Palliative care does not mean you're giving up on the patient, but rather that your focus is shifting from only curing to also comforting. Some patients are still receiving treatments while in palliative care, and others might not be any longer. Some specific examples of palliative care include the following list you see here on the bottom of the slide. There are, of course, many others. Pain management is huge, and we can see that a variety of modalities can be utilized to help with physical, emotional, as well as spiritual pain. Pain medication is commonly used, but it's not the only option. Massage, physical therapy, yoga, acupuncture, they can all be helpful. So too can counseling, meditation, biofeedback, even visits with clergy or other spiritual leaders. Many treatments and medications come with uncomfortable side effects, and for that reason, the palliative care team will also try to help relieve some of these effects, including attempts to reduce nausea, anxiety, depression, constipation, insomnia, fatigue, shortness of breath, and others. I remember when I first started working in hospice as a social work practicum student. I had a hard time differentiating between palliative care and hospice at first. Then I worked with patients, and I was able to see firsthand how there can be an overlap, but they can be separate as well. For example, I had a patient with congestive heart failure. She wasn't on hospice, but she still wanted to be comfortable and have her pain and symptoms managed. They were able to drain fluid from her abdomen since it was becoming distended and causing her both pain and pressure. They wouldn't have drained the fluid if she was on hospice, but she was receiving palliative care instead at this point and was still trying to manage her disease. Another example was with my paternal grandfather. He had COPD and was declining. He still wanted treatments to try to get better, even though it wasn't really working. They would come in and they would suction the secretions from his lungs to try to make it easier for him to breathe. There are many other examples we could use, but the most important takeaway point here is that palliative care helps support the patient and their family as they're coping with a serious illness. Managing pain, discomfort, and side effects are an important goal, as are helping the family communicate and talk about the patient's condition. Hospice is similar to palliative care, but it's intended for patients who are terminally ill and have received a diagnosis of approximately 6 months or less to live. With hospice, the goal is not to extend life or seek curative treatment, but rather to comfort and companion the dying. Helping reduce pain, take care of any unfinished business, and sorting through affairs are an important part of the hospice approach. There's an interdisciplinary team involving a medical doctor, nurses, a social worker, a chaplain, CNAs, volunteers, and even a bereavement coordinator. Hospice is offered through Medicare Part B, and the purpose is to make the patient as comfortable and pain-free as possible while supporting both the patient and his or her family. Dame Cicely Saunders founded the first modern hospice in London in 1967. In meeting with her first patient, she said the following, quote, "You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live until you die." Having an understanding of this helps us recognize that indeed, hospice is not a death sentence. Rather, it reframes the hope for quality of life through one's final days. As we wrap up this first part of lecture, I'd like each of you to read the short article that I posted in Doc Sharing. It's entitled, "Healthcare Costs and Choices in the Last Years of Life" by Ian Morrison. It's easy to read and it has a nice balance of overall statistics and big picture issues brought down to a personal level that we can relate to. He looks at end-of-life care within the larger context of our U.S. healthcare system, and this is a great fit for what we're being introduced to and talking about so far in the class. After you read the article, I'd like you to consider the following questions. What surprised you? What reinforced information that you already knew or suspected? What did you learn from Ian's article? And how can you use this to provide better end-of-life care for your patients, or maybe even your family members? Explore these takeaway points, as they should bring together what we've been talking about and exploring so far in class. Okay, that's it for this part of lecture. Of course, if you have any questions, just let me know.